So hi, everybody. My name is Tony Bryant. I am the president of the Hearing Loss Association of America, Mission Viejo chapter. And as some of you are very much aware, we used to be the Hearing Well Club, but we've merged with the Hearing Loss Association with the idea of serving all of South Orange County instead of just pinpointing Laguna Woods. So welcome, everybody. I want to just give you some quick instructions. Hopefully this will be very quick because some of you are familiar with the Zoom instructions. So if you're on a desktop, which is like a laptop or a computer or a Mac, then these instructions are for you. I do want everybody to be aware that this meeting is being recorded. So be sure to smile because you're on camera. And this will, because it's recorded, it will be available online in the chapter's YouTube channel. And I'll tell you about that as we go along. I want to tell you the captions are available. If you see them now, there's nothing for you to do. If you don't see them, you need to look. Well, let me just. Yeah, go to the bottom of your screen and look for the closed caption or the live transcribe button. Now, if you're not seeing the toolbar, tap somewhere, using your mouse anywhere on the screen so it'll pop up. It disappears when you're not doing anything. So, so have it pop up, click on the CC icon, and then click on subtitles. See where it says show subtitle? I want you to know that the captions are movable. So if where you're looking at them is covering up anything, you can grab it with your mouse and move it around the screen to where it's better for you. Okay. There's subtitle settings. If you want to make the captions font bigger or smaller, you can make that adjustment using subtitle settings. Okay, so there is a full transcript is available, and you can see it as it's running, in addition to the closed caption box at the bottom.
Have to get the video.
It may get in your way.
Randy.
All right. I'm going to ask everybody to mute themselves. Okay, here we go. You can click on it and have them pop out, and you can move them to the side. That's just something you'll have to experiment with. It's not available in full screen mode. So full screen or not, that's up in upper right-hand corner under view. Click on view, and then you'll see you'll have speaker view, gallery view, and exit full screen. Okay, I'm going to move quickly here. So this is the chat box. You see this? This is, if there's a message there should be a red indicator that there is a message waiting for you to see. If you would like to send a message, you just type in where it says type message here and press enter, and everybody will get that message. So if you want to send something just to Alan, tech support, then you would change the little drop down from everyone and point to Alan's name. And then his name will appear there, and then type in a message, and only Alan will see your message. You can send a private message to anyone. Okay. Again, you can pop that out using this little arrow down. That'll pop out, and you can move that conveniently anywhere on the screen. Use the chat function to ask for technical support. Really important for this meeting, is I want to make you aware of something called reactions. If you're not seeing reactions, you need to update your Zoom software. But the latest one shows reactions, and down here, the biggest button, when you click on it, the biggest button available is raise hand. Right now, I can only see 24 people in this meeting, and we actually have 42 people, but I cannot see everybody. So if you're waving at me, I may not be able to see you. So it's important that you use the raise hand function. Okay. Also, this is a clapping, and this is okay, yes, no, different little signals. Okay. The Hearing Well Club has merged with Mission Viejo, as I just told you, was in Hearing Well Club served Laguna Woods since 2012. And only January 1st did we merge to Mission Viejo chapter. And HLAA, Hearing Loss Association, will provide much rich resources on behalf of all people with hearing loss. Okay. I want to recognize our officers. Vice presidency is open. So we're looking for somebody to be vice president. Judy Mandel, who's with us today, is our secretary. Our treasurer is Jeff Chess, and our program director, much appreciated, is George Gross. So he's here today too. We do not endorse any single product or service, and the meeting is intended to provide information, education, and support. So I want to thank Caption Call. They actually sponsor the captions for this meeting. Joe Gale is our captioner today, and she hails from Illinois. So she's online with us from Illinois and providing captions. So welcome, Joe, and thank you. So Caption Call provides landline phone service for landline phones, smartphones, iPhone and Android now, and iPad. And something new is if you don't have internet at home, no problem, they'll provide it for you. And if you don't have a phone line, they'll provide it for you. So it's worth checking it out. I'm going to tell you, I'm sorry the phone number is not there. The phone number, if you're interested, is 877, Alan, if you could put this in the chat box, 877 557 2227. We are a 501c3 tax-exempt chapter, and we need your support in the way of donations. You can make those donations online in our website, HLAAMV.org. We are putting together right now a brand new website. There's a lot of expenses in pulling that all together, and we need your support. Thank you. Okay, I'm the president. We're on Twitter and we're on Facebook, so look for us. These links are available on our website. And so here I want to tell you, this is our YouTube channel. And on our YouTube channel, you are going to find all of our recordings. And if you go to videos, you will see them in the newest one is going to be first. And I have a favor to ask of everybody. When you get to the website, the YouTube website, please click thumbs up or thumbs down for the video that you're watching. Subscribe, and you can also make comments. So that's one way. If you subscribe, and there's actually a little bell. There's a little bell here. If you click that, you'll get a notification when a new email has been uploaded. Okay. I'm going to stop sharing that. So let me get through my notes here. We want to move right on to Dr. Djalilian's presentation. I want to tell you a little something about him. I've known Dr. Djalilian now several years. And every time I go down to UCI to have an adjustment on my cochlear implant, I'm always running into him and Dr. Harrison, Lynn Harrison in the hallways. So I really enjoy seeing you. His expertise is complex ear surgery. He does cochlear implants. He treats hearing loss, balance disorders, facial nerve paralysis, and skull-based surgery. He is a professor of otolaryngology and biomedical engineering. So he's way up there, and he does research in addition to seeing patients, teaching students, and he does research as well. And today, the focus of his presentation is going to be the latest in research from UC Irvine Center in Irvine. So I am going to pass this on to you, Dr. Djalilian. Welcome.
I appreciate your very, very kind introduction, and I'm honored and happy to be with everyone. Let me just share my screen here. Okay, can you see my screen?
We can see it, yes. Great.
Okay, excellent. So as Tony mentioned, in addition to seeing patients, I do research, and so we'll talk about some of the projects that we've been working on. Most are hearing related. There are a couple that are sort of in that realm of the ear, but not hearing. So we'll talk about hearing loss and hearing aids. We'll talk a little bit about tinnitus, and then dizziness, and then last we'll talk a little bit about facial paralysis. So, one of the questions always comes up is why do you do research? And, the way I look at things is when I see patients, there's only a limited number of patients I can see. There are only, certain number of people I can see per day or per year. And really research allows me to find ways that I can help many, many more patients than what I can see physically just by seeing people one at a time. So the things that we're looking for are understanding what causes the disease, how do we treat these diseases, can we come up with new devices or new medications to help with this, are there ways we can actually prevent the disease? And really without research, we really would be back practicing what, people have been doing for, hundreds of years ago. And so it's really modern medicine progresses because of research. Every new treatment has years of research behind it. We kind of just see the end product, but not realizing there probably was 10 to 15 years of work behind that product. And then part of the other thing is that we really need to teach this to others, because I only have so many years I can do this. So I want to make sure I can cultivate the same curiosity for solving big problems to a whole new generation of people. And that's sort of the other reason we do this. So very, very brief, and I'm going to put this on so you can see. So sound is basically vibration of air molecules. So my voice comes out, it vibrates a little membrane in actually a microphone, and then that information is transmitted electronically to your speaker, which then vibrates the air on your side, and that vibration then ends up inside your ear, which then vibrates the eardrum, vibrates these little ossicles, the little bones, which then vibrates the fluids inside the inner ear, and then that vibration is then translated into electrical signals that are sent through your hearing nerve to the brain, and then the brain kind of puts it all together and figures out what all of it means. The primary cell that figures out, whether you can hear or not, is the cell that has these tiny little hairs on it, the so-called hair cell, This is a what we call an electron microscopy image. So this picture is like 100,000 times the size of the actual cell. So this is a very, making it very big. And this is sort of a schematic of what the cell looks like. And it has these little nerves, and it's got these little ridges. And then those little ridges will vibrate, those little hairs, if you may. And that's how then it picks up that there has been sound, and then the information is transferred to the brain. So I'm sure you've probably all had a hearing test at some point. You know, when we look at the hearing test, it sort of really tests a limited portion of our hearing. We can actually hear much lower frequencies and much higher frequencies when we're young. Usually at around age 20, we start losing some of the very highest pitches, which is it goes up to 20,000, and this is 8,000 is what we test normally. And the reason we test this limited set of pitches is because those are the pitches that are most important for speech. So that's why we test those frequencies specifically. And then, you know, then there's the level of hearing, and the higher up you're in the graph, the better. And so people who are, you know, above 20 are considered normal, you know, but as we age, our normal changes. So by age 70, normal is about 30, age 80, it's about 40, age 90, it's about 50. So normal changes with time. So if somebody has a hearing loss, you know, that let's say this is what their hearing test looks like, then they're going to have difficulty hearing certain sounds of speech. So for example, the F sound, the S sound, the TH sound, those are all very high frequency sounds. So if you have a high frequency hearing loss, you'll have difficulty telling apart a word like fat or like sat. So he sat on the chair, or this person is fat. So because unless you're looking at their lips, you're going to miss it, because the F and the S sound are very high frequency sounds. And if you have a high frequency hearing loss, you will miss it. And part of what we do, of course, is try to educate not only clinicians and researchers, but also to teach the public about the dangers of noise-induced hearing loss and what we can do to prevent hearing loss. So as you know, about 30 million Americans have hearing loss. It is the most common thing that can go wrong when a child is born. So of all the problems you can have at birth, hearing loss is the most likely thing to be present. As you know, of course, it's very common as we age. It's sort of something that everybody is going to develop, kind of like as our vision gets problems, you know, our hearing will get problems. And worldwide, it's the second most common cause of people's inability to work. So it's a huge problem. And really, noise-induced hearing loss is become a very problematic issue, because in the old days where people would listen to music on their own, you know, you'd listen to a tape, you would listen for 20, 30 minutes, and you had to stop and flip the tape, and you couldn't turn up the music too loud. But now with headphones, quality sound being so good, digital music having such good quality, you can listen to music for hours and hours at a loud level. And so unfortunately in teenagers, that's becoming a big problem. So we're trying to educate the public about this. Now, switching the gears to hearing aids, well, when people have hearing loss, a lot of people don't end up getting hearing aids. And the main reasons are the sound quality, the stigma attached to wearing a hearing aid. For some reason, it got into our culture that if you wear glasses, it makes you more intelligent, but wearing hearing aids doesn't make you more intelligent. You know, why that is, I don't know. I think it's probably just marketing, but the reality is both are helping you sense something that you couldn't sense as well before. So why would wearing glasses be a fashion statement and wearing hearing aids not a fashion statement? Now, middle ear implants can overcome one of the problems, which is sound quality. And so this is just the basic concept of how a hearing aid works. Sound comes in, a hearing aid amplifies the sound and then puts it into the ear canal, and then it vibrates the eardrum. One of the problems with this, as you know, if you've used hearing aids, is some of that sound will escape around that hearing aid and get into the microphone again. And that's what causes whistling of hearing aids and feedback on hearing aids. Now, the idea behind an implantable hearing device is it takes the sound and it uses it to vibrate the little bones behind the eardrum. So this is an example, one of the commercial devices that's available. Basically, it needs a little surgery. You implant this little magnet behind the eardrum, and then you use the hearing device to kind of vibrate that magnet, which then vibrates the hearing bones. That provides a much better sound quality because it's more natural than using a tiny little speaker in a very tiny little space in our ear canal, which can cause this reverberation that you sense when you have hearing aids. So a few years back, we started looking at how can we solve all the shortcomings of hearing aids. And sort of my general approach to research is, how can I come up with a low-cost solution that many people can use? And then how can I come up with maybe a very sophisticated solution that can overcome problems, but might be a little more expensive, but can overcome all the other issues that we otherwise have with like devices. So our first sort of crack at this was this app that we created because we thought, what is a hearing aid doing? It's taking sound, it turns it into digital data, it then amplifies it, and then it puts it out in a speaker. It's essentially a tiny little computer, in your ear. So we thought, can we do that using the phone? So the iPhone is essentially a mini computer in your pocket. So we started this iPhone application. Probably this was actually one of the first, actually it was the first hearing aid application on the App Store that could actually test your hearing, and then it would amplify the sound, and then it would put out the sound. So it would actually do a hearing test, and then based on the hearing test, you could then adjust. It would automatically give you amplification, but you can make adjustments and stuff like that. Now, one thing we found in the last year was a lot of people use their phones to stream movies or music or whatever. And the hearing aid app that we had really was primarily for people having conversations. And unfortunately, in the last year, not too many people could get together to have conversations. So we said, let's come up with another app that can actually overcome that. So we actually made this other app called Hear Better app. And this one allows people to use it for streaming videos. So it does a hearing test. It figures out where you have hearing loss and then amplifies sound in just those frequencies specifically. So you can watch a YouTube video of my lecture later on. I'm just kidding. And then you can amplify the frequencies, let's say, that you need, instead of turning up the volume on everything that is being said. Now, the other solution that we started working on probably about 10 years ago or so is this device to try to overcome that sound quality. So as I mentioned, there are implantable hearing aids that can overcome the sound quality issue. The problem with them is that they require surgery, and because they're not covered by insurance, they become very expensive. So one of the common hearing aids, implantable hearing aids that are used, costs about $29,000 per ear. So you can imagine that there are very few people in the country who can actually afford that. So we thought, how can we solve the sound quality problem without having a very expensive device and something that doesn't require surgery? So we thought about fundamentals. I always go back to what are the fundamentals of this problem? And let's break this down into its most basic component, and then let's solve each one of those basic components. So what we did was we thought, if we can, instead of vibrating the bones from behind the eardrum, which is what implantable devices do, let's vibrate the bones or the eardrum on the outside of the eardrum. So this is the concept we came up with, is that a hearing aid that would get placed deep in the ear canal and then can directly just vibrate the eardrum. So normally you're taking sound and making it louder, putting it into your ear canal. And that's what creates a lot of the distortion and the sound quality problems. If you actually directly vibrate the eardrum, then you can actually overcome that sound quality problem. So that's sort of what our original concept was. So you don't have to occlude the ear because you're not producing sound, so it doesn't have to worry about escaping. There's no feedback because you're not producing sound with the device, you're just producing vibrations. And so this is actually the first time we ended up putting it in, and as you can imagine, these efforts take very large teams. And this is only part of our team that we use for the clinical study. So this is actually me here. This is my engineering partner that we worked together to develop this device. This is one of our PhD students. These are the 3 MDs that were doing research on my team. There was like another 2 PhD students on Dr. Bachman's team. And sort of this is the device, the first time we put the little, what we call actuator, the little kind of like speaker, if you may, right on the eardrum to vibrate it. And then we tested on the other side, tested his hearing to then see how well our device matches up with normal hearing. And that was actually pretty successful. So we then worked on making the device so that we could actually hook it up to a regular hearing aid. So we use the electronics of a hearing aid, but used our device to vibrate the eardrum. So this is actually our first iteration of the device that you could wear and kind of walk around with. This is one of our engineers in whom we put the device. This is me here. After we put the device in, we got him walking around and running and upstairs and eating and drinking and to see if there's anything that would dislodge this. And it turned out that it stayed pretty well in place and the sound quality was still very good. So that encouraged us to do further research. Now we're working on building a device that is all kind of contained into a tiny little device that would all go in the ear canal. So it has the battery, the electronics, and then the actuator all in the ear canal. And because this device doesn't produce sound, it's actually much more efficient with power. So a battery would last a lot longer. So that the goal, hopefully, is based on the calculations, would be that this thing would last in your ear for about 3 months. So you put it in, you kind of put it in and forget about it. For 3 months, you have it in there, it's working, it's doing its thing. Then you go in and then switch it up to a new device or change the batteries or something. So what we're working on currently is we're trying to get some funding to make the next generation device, to make a smaller device, and then run a trial of about 10 patients for 30 days. And if that's successful, then we're going to do a 3-month trial. And then our next step would hopefully to try to get this device commercialized and try to get so that people can actually buy this. So we can partner with a company to make the device. Now, we're working on a fully packaged device, and then, as I said, a longer term trial. Now, cochlear implants, I'm sure a lot of you are familiar with, some of you may be wearing. There are devices that help kind of restore hearing for people who've lost significant hearing. It helps in speech understanding, but one of the things that we've been working on is how do we make the speech understanding even better? How can we improve music perception? How can we reduce the cost of the implant? And then can we do a better job preserving people's hearing while we're placing the device? And then can we make a device that can last forever, hopefully, or inside without the need for outside device? So we're working on this auditory nerve implant, which is a device that goes into the nerve and stimulates the nerve directly. And then that's a device that a couple of my collaborators and people in our department have been working on. And this theoretically could improve music perception. It could become a fully implantable device. And this device is now undergoing longer term trials in animals. Now, the Holy Grail is, of course, restoring hearing, getting those cells to kind of go back to normal. And so those will take, a bit more work. One of the targets of treatment is these things called mitochondria, which are inside the cell. They're involved in taking care of the toxicities that occur in the ear, in the cells. And so one of the reasons people lose hearing is because these get damaged over time. And that could be from noise, it could be from aging. And so one of the things we're working on is kind of coming up with either an oral medication or an injection that can help restore the function of these mitochondria so that we can hopefully have people preserve their hearing so that this is something that people would take, let's say, on a daily basis to prevent the age-related hearing loss, for example. We're actually hopefully hiring somebody soon who's going to that's going to be his focus of research, is developing therapies for this. Now, tinnitus is a problem that's very common. It's just as common as hearing loss is. There are some people who are very, very disabled by it, and it's a significant problem in the military, and it's a very, very costly problem. On a yearly basis, the military spends $1.5 billion compensating veterans for tinnitus. And really, the sound perception, as you know, comes in the brain. And we've been working on really attacking the perception and the production of the sound. So the sound perception is from the brain. The production is due to hearing loss and loss of nerve input. So we started research on this starting in 2006. One of my partners, Dr. Fanggang Zheng, his research ended up in this device called the Sound Cure, which unfortunately now went off the market about a year or two ago. And then we worked on an internet-based approach. So we came up with this, like a website that people can identify their pitch of their tinnitus, and then we can use music and sound to help suppress their tinnitus. And then what we started realizing is that tinnitus also is, there's a significant role of stress and anxiety and migraine in tinnitus. And so now we've been working on a cognitive behavioral therapy that would be done online. So people could essentially log in and go through some things, essentially going through what a psychologist goes through with people, but doing it online so that it's easily accessible and less expensive for people. So that's one of the things we've been working on. And we just recently completed a clinical trial of this, and it worked very well for tinnitus. So we're very excited to expand that further. So this is the trial I was talking about. We have now actually finished, since I made this slide, we've finished the 97 patients total. And we've also been working on a combination drug to treat tinnitus that works on migraine therapy. And we've so far enrolled about 21 patients, and that's worked pretty well. We're also working on a kind of, as I said, a sophisticated device, and that would be to solve the problem with tinnitus, which is to stimulate the cells in the inner ear so that we can get more signal going to the brain, which then helps reduce the tinnitus in the brain. So we started by doing electrical stimulation. This is one of our first patients that we did. This is Professor Zhang, this is me. I put the device in her ear through the eardrum and stimulated the inner ear through there. And in a small trial that we did, on the vast majority of the patients, we could make the tinnitus go away, at least temporarily, when we're doing the stimulation, which made us think then maybe we should expand this and develop an implantable device. So that's what actually we've been working on now for the past year. And I have like a team of several engineers that I work with for that. So we've been working with Professor Green and his team. We have hired some people and working on the implantable device. There's a component on the outside and a component on the inside. Now, we've also been working on migraine and ear disease. What we found is that migraine is significantly involved in a lot of ear conditions, and we've done a lot of clinical research on this, and we've been actually probably the leader in the world in looking into the effects of migraine in ear diseases. And what we have found that initially that there was a very high prevalence of it in Meniere's disease. And then we were the first people who actually did a clinical trial where we gave patients with Meniere's disease just migraine medications, didn't give them any of the normal Meniere's treatment. And we were successful in treating Meniere's as good as actually the surgical procedures that are done. And we reported this condition that had never been described, of this sensation of ear fullness that can be caused by migraine. We're the first to treat sound sensitivity and this other condition of dizziness related to like boat and plane rides with migraine medications. And we've actually recently been looking into sudden hearing loss and been treating patients with migraine medications in addition to our normal therapy. And we've been finding that we get much better outcomes of hearing loss when we treat them with migraine therapy. So we're hoping to get some funding to do a clinical trial using these migraine medications for Meniere's disease. This would sort of help convince other clinicians to do this, hopefully, so that we can, again, help millions of people. That's being the goal here ultimately. Now we're going to shift gears a little bit to balance. Balance is controlled by multiple systems, including the inner ear. Falls are a big problem. Hip fractures are a big problem, and they're very, very costly to the healthcare system. You know, the best treatment is really going to a physical therapist. You go into this big machine, it costs like $80,000, and the therapist puts you through this and then, you know, gives you some therapy. And we thought, can we come up with a more affordable way to do this? So we came up with this insole that goes in the shoe, because that's what that platform does. And can we come up with ways to make people do the therapy at home to improve their balance? So we came up with this game that people could play, where you move and then the actual character on the screen will move. So you do various things. So it essentially gets people more active and improves their balance by doing the various things they do. So we want to do these things to develop these, integrate the game together, develop more games for this, and hopefully we can get this to a trial. So we're looking to get funding for that hopefully soon. Now, again, our now more sophisticated solution is a device that would actually go into the ear and replace the function of our balance organ. So if you think of cochlear implant replacing the hearing function, this would be a vestibular implant, which would replace the balance function. And we first reported a design of a device that can actually do both, to actually improve hearing and balance. So that's the device that we had conceptualized. Now, another thing that we've been working on is balance rehabilitation. Requires a lot of head movement and eye movement and stuff. And it requires visits to the physical therapist, and we're trying to think of how can we do this less expensively for people. And using these goggles that are used for gaming technology, we've been working on a way to reduce motion sensitivity that people have, and to help them improve their ability to coordinate their eye movement with their head movement. Another device we've been working on is how to diagnose ear infections. So we basically, one of the problems that when somebody goes into the doctor, a child, the primary doctor is only really about 50% accurate. So it's essentially like flipping a coin, whether they have an ear infection or not. So I thought about this device a few years ago, thinking, you know, what does our brain do to tell that there's an infection? It's really, it looks at colors, it looks at shades, and can we computerize that? Can we come up with a computer that can actually do this? So we actually did it. We made a big device, and essentially it was a computer. It was hooked up to a device we put in the ear, and we found that actually was very accurate in telling if somebody has an infection or not. And then now we have actually built a handheld version of that. So it's like a little otoscope. So this would be, you go to the doctor, they click a button, and it'll tell them if the child has ear infection or not. So this takes the guessing out of it. So we're hoping to do a clinical trial of this sometime soon. We're also working on a gel material that has antibiotic and growth factors to help close holes in the eardrum. So we've been experimenting with that as well. I'm going to skip this. This is more related to sinusitis and stuff, but this is a test to try to tell apart sinus infections, allergies, and a common cold, which can all look very similarly. So people a lot of times get antibiotics prescribed to them, but they really don't need antibiotics, and it's just really a cold or it's an allergy. And this test, hopefully, I'll be able to fix that. And then last, the facial paralysis. One of the problems is people develop facial paralysis is they develop kind of a problem where one side works and the other side doesn't, or one side works and the other side is abnormal. It doesn't work properly because the nerve got mixed. So now we've been working on a device that can actually, it's like a little electrode that goes around the good nerve, takes a signal, and then sends it to the bad nerve. And then we send that signal so that then they can get coordination of their face. And that actually has been pretty successful in the short term. Now we're trying to get funding to do long-term experiments in animals to prove that this works and it doesn't cause any issues. And hopefully we can make a device for people. So hearing is really the method that we communicate with others. And as you know, Helen Keller, who is both deaf and blind because of this genetic condition, she said really that if she had the option of getting one of them back, she would rather get hearing back, because she said vision really separates her from things, but hearing separates her from people. And really hearing is what allows her to connect with people. And it's one of those things that I think a lot of people take for granted. Everyone's worried about their vision, but not as many people are attentive to protecting their hearing. And hopefully we can change that with time. And balance is one of the other things that we probably take for granted. It's one of those things that we don't think about until we lose it. It really creates the mobility that allows us to participate in our environment. If you think about, if you don't have balance and you can't leave the house easily, then it's hard to interact with people. Now we can do it with Zoom, but before and after the post-COVID world, I think, again, balance is important. So I think one of those things that we've been trying to do is help everyone restore that balance. So our group, we are 27 scientists and clinicians in multiple different schools at UCI, trying to do things to help people with hearing loss and balance problems and the other things I mentioned. And we span pretty much every discipline there is. This is my team that helps me with research. We have undergraduates, we have medical students, we have residents, we have postdoctoral research fellows, and then my engineering group that I work with, the facial implant group, and the migraine and tinnitus group. And that's all I have. Thank you for coming in. I really appreciate your invitation. I'd be happy to take any questions you have.
Okay, I have a couple of questions that came in by email.
Sure.
So I think, Gail, I know you're on this call. Would you like to ask your question yourself? Let me get started here. The question, first of all, Gail is a patient of yours.
Yeah.
Okay, you're there.
Yeah, I've been a patient of Dr. Djalilian when I had my Meniere's disease. I still have Meniere's disease. I don't get as many vertigo spells because of Dr. Djalilian giving me that migraine medication. I've been pretty stable. I did have COVID in October, and for some reason, the COVID triggered my vertigo again, terribly, where I had to go up on the medication a little bit. And for 2 weeks, I had so much pain in my ears and everything. I wonder, was some correlation between Meniere's migraines and why did I experience that in particular, doctor, when I did
Sure.
have COVID?
Yeah. So any illness you get is a stressor to your brain and your body. So when you get a stress to your body, the brain responds to it in the same way that you get a psychological stress. So if, let's say, you're upset about something, the brain reacts in the same way as if you get a cold or you get COVID. Now, interestingly, migraine also becomes active. So that stress is what sets off the stress reaction of the brain to the illness is what sets off the migraine and then thus the Meniere's symptoms. Some people after vaccination can also get migraine. That's normal. It's temporary. It's only for a couple of days usually, and it passes. But don't be alarmed that happens after vaccination. It's not a big deal. Just usually we ask patients to drink lots of water, stay well hydrated, and all that stuff, to do all the other things you do to prevent migraine. That should help. And then there's another question that was sent to me via chat. And it says that years ago, they developed a stapes surgery, which this person's mother had. But she thinks that her hearing loss is not that. And it says, what is the possibility of surgery for other types of hearing loss? So it depends on the cause of the hearing loss. So if the cause of the hearing loss is the little bones in the behind the eardrum or a problem with the eardrum itself, then that we could do surgery to fix. If the problem is the inner ear, unless it's a very severe problem, we usually don't do surgery for those. First, you would do hearing aid And then if hearing aid's not beneficial and someone has a severe loss, then a cochlear implant would be the next step. Implantable hearing aids, we're really not doing as many, partly because the technology isn't that good. And honestly, my father wanted to get an implantable hearing aid. And I said, wait a little bit, because I want sort of the second generation devices to come out. Like one of the best devices really is you can't charge the battery. So the battery runs out, you got to get another surgery to get the device removed. And, you know, you're committed to the surgery every like 5 years to get your battery replaced. And that doesn't make any sense to me. I told them, wait for their next generation. And, you know, get the best hearing aids you can, because that's sort of what usually does the trick. And so, so not every hearing loss is surgically treatable.
Okay, Alan, you want to unmute yourself?
Yes, Anne has a question for the doctor.
Anne?
Yep. Dr. Djalilian, I am the audiology advisor with the group for the Hearing Loss Association. And I just wanted to thank you for all the information. It was wonderful. My question is, when you were talking about tinnitus, we have a lot of patients who come into the office. And do you find through your research that utilizing a hearing aid first in and of itself can help with the tinnitus? And if so, kind of the percentage of that? And the second portion of that question is, do you find, or have you been doing research with your cognitive therapies on using the Zen program by Widex and or the tinnitus masking programs that are currently in hearing aids?
Sure, thank you for the question, and it's very nice to meet you. Yeah, so if somebody has hearing loss, the best way to initially treat tinnitus is to give them more sound. And so if you use a hearing aid to give more sound through the ear to the brain cells where it's being produced, then that sort of quiets down the tinnitus. So a lot of people who have hearing loss and they use hearing aid, and their tinnitus improves. Now, hearing aids that can amplify nothing, so if it's quiet, then you use a masker feature or something on there. We personally haven't used the Zen program or other ones that are on the hearing aids. We did actually look at our sound therapy and look at the white noise, which some of the devices just produce white noise, which is just kind of like a sound of the rain. And we actually took a group of patients where we treated them with our sound therapy and then treated the other group with the irregular white noise. And then after a couple of months, we actually then switched them to see if which one got better when they were better. And what we found is actually so-called customized sound therapy tends to work better than a generic sound, but we were just comparing white noise to the protocol that we have developed for tinnitus. And then I think that was it. Is that correct? Did I cover everything?
Well, then the question is, on those people, did they have hearing loss when they had the tinnitus, such as in the military, or are these people with normal hearing who are experiencing tinnitus? Because we have had great success with hearing aids, and when the hearing aid is fine-tuned to the hearing loss, you are, you know, it affirms that the brain is looking for that extra sound that it's not getting. And I just wondered whether or not your studies currently are with hearing impaired or normal hearing people who are experiencing tinnitus.
Yeah, so we actually, in our studies, we include both groups. Unless somebody has severe hearing loss, we don't include them just because we can't get enough sound to them sometimes. But we include both groups of people with hearing loss and those without. And then we just have them use the sound therapy sort of alone without the hearing aid for like a 2-hour period of some time or something. And these are, if they have hearing aids, we want them to be chronic hearing aid users, not someone who just got the hearing aid, because the improvement could be from the hearing aid and we might think it's from what we're doing actually. So we try to control the study as best as we can.
Okay, I have one that came in on email before we go to the next person. So this is for Mustafa, and he is here in the meeting. Couple of things. He wants to know about itching in the ear. Is this a dermic problem or something else? What may be the cause, and what do you do about it?
Sure. Itching in the ear is primarily from dryness, and sometimes could be from this little fungus in the ear canal that lives on the skin that a lot of people have. So it's generally what we ask people to do is just keep their ears moist with like oil, like once a week or twice a week. Use a Q-tip to put some oil in there, or just drop 1 drop of oil in there. And then avoid like getting shampoo and soap and stuff in the ear canal. That tends to dry the ear canal and cause more itching.
Okay, the next question, same person, regarding earwax. What causes it? Can it be prevented? Can it be reduced? Boy, I'd like an answer to that one. And
sure. So
how could it be cleaned out without damaging the eardrum?
So earwax is produced by these glands in our ear canal. Its main purpose is to protect the skin of the ear canal from infections. So we actually want some wax in the ear canal. Now, the earwax slowly moves out on its own. However, as we age, our wax tends to become a little drier, and that process that moves the earwax out is slower. So then it tends to accumulate a little more. And then, of course, if people wear hearing aids, it prevents it from coming out, so it tends to accumulate a little more. So, what can you do at home? If you've never had problems with your eardrum, you don't have infections or anything like that, you don't have any kind of immune suppression or like, significant diabetes, then we ask you to use like these over-the-counter kits or some drops that soften up the wax, and you kind of use some warm water to wash it out. I like to use a mixture of alcohol and vinegar. Maybe like once a week, you kind of just flush the ear canal with it, with just like maybe, a teaspoonful of stuff. That helps reduce the amount of it a little bit at a time. And the benefit of alcohol vinegar is that you're not going to get an infection from it, whereas water in some people can cause an infection if they manipulate their ear too much.
Okay. So we have some hands up here. We have Rena. Rena, you have a question?
Hi, everybody. Yeah, I was wondering, I moved to Nevada, southern Nevada, and I was I wonder if it's some like facility there like yours that can I go to and you're like involved in these researches that you do, some university, if you can refer me just or give me some information. So
sure. You said Nevada, is that what you said? I'm sorry.
The southern Nevada. Yeah, it's Las Vegas and Henderson. So I was,
Okay, got it. Yeah, so I would go to they're not doing the research that we're doing, but if you want to see like an ear specialist, there's only one in that area that I know of. His name is Dr. Eng. It's N and a G. So there are no vowels, it's just NG, but it's called Eng. He's at the University of Nevada in Las Vegas Medical Center.
Oh, so there is University of Nevada in Las Vegas too, like UTI, right? Just if we can.
Correct. Yeah.
Yeah. I can.
They don't do a lot. As I said, they don't do the type of hearing research we do, but there is an ear specialist there that you could see. Yeah.
Oh, okay. Thank you very much. I appreciate it. Thank you.
You're welcome.
Doug Richards?
Yeah, hi. Glad to be a part of the chat today. I have a profound bilateral hearing loss, cochlear implant on the right, hearing aid on the left. And as my hearing loss has progressed, I've been very intrigued about the research of hair cell regeneration, especially that which happens in certain animal species. And I know that there's a great body of research to look at hair cell regeneration. On one hand, you and your colleagues are efforting a lot on the technology and the hardware. where are we? How many more years will it be before you think we will have that capacity to actually heal those hair cells, either through stem cell or other technologies? Because that might inform whether or not I get a second cochlear implant or wait to see. I mean, is it 10 years out? Is it 20 years out? Yeah. What are your thoughts on that?
Sure. It's a good question. And, you know, I about 20 years ago, my research initially was all for hair cell regeneration. That was my kind of goal. But what I realized at the time and the method that we were using, that it was going to take many years to get to it. And I kind of like to see the fruits of my efforts, you know, while I'm alive. So I sort of switched gears to developing devices, because you could go from zero to a device in people in, you know, 5 to 10 years, whereas hair cell regeneration now, you know, 20 years, we still are not there. And it's probably, realistically, it'll probably be at least another 10 years, because there are a lot of companies that are now developing actually the technology. They're putting a lot of money into it. So I think we will get there. How soon, I really couldn't tell you. I mean, I think it'll probably be, you know, at least 10 years, 5 to 10 years away, you know, before we get for the point where regular hair cell regeneration is done. What their focus right now is on genetic replacement. So people have genetic loss and they can replace a gene. But for, you know, a hair cell is going to, for like somebody from age-related loss or something, it's going to probably be much longer.
Thank you.
Okay.
We are hiring a person to do that very thing. So we hopefully in the next couple of months, we're going to bring in somebody to develop a focus on that area. Yes.
Okay, good. So Barbara, you can unmute yourself, and anyone else that has a question, please use the raise hand feature.
Okay.
Hi, Barbara.
Hi there, Tony. I wear a single cochlear implant, which I've had for about 10 years. I have a particular interest in music perception. And I saw on your initial slide that you are working on improving music perception. And if so, I would love to know what particular approach or avenue you are using currently, and if you've discovered a miracle for me, that would be nice too.
Yes. Well, we're working on a miracle, but you know, the cochlear implants are very limited in what they are able to do, and that's because they can only stimulate so many areas of the inner ear. However, this new device that we're developing, which is a auditory nerve implant, that's sort of the goal of that device. One of the things is to improve. So right now, listening to music with a cochlear implant is like somebody playing the piano with mittens on. And we want to be able to take those mittens off and be able to more precisely stimulate nerve cells. So we're working on it. I wish we could do something for you right this moment, but right now the cats are the ones who are getting the devices, and so hopefully at some point we'll get it into humans. Our goal is to get it into humans, at least experimentally, in the next probably 2 to 3 years.
2 to 3 years?
Yes, that would be initially. These would be people who are cochlear implant candidates who could get the device. They would get the new device and they would get a cochlear implant at the same time. And then we can actually switch back and forth to see which one has better sound quality.
I would love to read about the research that you're doing right now on this. Where can I find some printed information about it?
If you just contact me, I can, actually, Tony has my email, but and I can send you some information about what we're doing related to that.
Wonderful. Thank you so much and good luck.
Thank you. No, thank you very much.
Okay, I have another question that came in email. I'm going to reword it a little bit. This is about using swimmers' earplugs. So are they helpful? Should somebody use it? And would you think it's a good idea to use them in the shower? What do you think?
So swimmers' plugs are really, the average person doesn't need to use them. They're really beneficial for people who have problems with getting chronic ear infections, or they develop issues with, the people who surf a lot and get exposed to the cold water and the wind and stuff like that. So for a regular person, they don't need to use it. But if somebody gets chronic ear infections, yeah.
Okay. We can't see you. Can you turn your video back on?
Yeah, I had to, I was between surgeries, so I have to actually just step in to just give them the okay on something. So just give me a second. So I won't be able to turn the video on right this moment, but I'm with you in spirit.
Okay. Well, I do remember when we scheduled this that you did have surgeries today. You were hoping you weren't going to be late. You weren't. You were right on time. And live questions, any hands up. So maybe this is a good time to say thank you very much.
No problem. I can answer questions. I just can't have the video right.
Okay, I understand. Okay, but I think we've run out of questions right now. Anybody else have?
Okay.
Oh, okay. Gail Perlow, you want to unmute yourself?
Hi. I love the question about the earplugs for swimming. One of the things that I have a challenge with is that I have small grandchildren I want to swim in the ocean with and the pool. And when I sit at the pool, I take my hearing aids out because of the playing in the water, and I have no communication or conversation during that time period of being in the pool or the ocean. Is there any hearing aids for profound hearing loss that is waterproof?
That's a good question, and I don't know of any devices. I mean, other than an implantable device. I'm just trying to think. I mean, this would be in the ocean, or be in the swimming pool, or what?
Well, I mean, I'm a swimmer and I enjoy playing, and also I like to snorkel, so I have no sound. I mean, it's scary. I can't even be, if my grandchildren are in distress, well, I'm in the ocean with them, I can't hear them. I have regular hearing aids. I won't wear a $5,000 pair of hearing aids and chance it getting broken from the water.
Yeah. I must say, I don't know, but maybe the audiologist who's on they can help us with this.
Okay. So implantables are the solution on this one for the people that have the surgical implants then.
For your level of loss. So there is a device called Lyric device, but that's really for louder and just a little bit into the moderate range. Yeah, you could get it wet. It tends to lose its battery a little bit faster though. But for severe loss, I don't know of a device other than an implantable.
Yeah, I did wear the Lyrics in my earlier times, and I could tell you there was a lot of problems with the Lyrics. So I would not consider that.
Yeah, I mean, a cochlear
Okay.
implant, you could get wet. I mean, if you have a cochlear implant, but that's also an implantable device. So.
Okay. All right. Thank you.
This is Tony. I'm not really sure that that a cochlear implant is going to be any better because you still have to have a processor. I have a cochlear implant. Med-El makes a wrap for the external piece. So there is like a swim cap for my processor. So I think the best thing to do is through your audiologist, find out if your hearing aid manufacturer provides the equivalent of a swim cap, for your hearing aid.
Oh, that's a good idea. Thank you.
Yeah. Okay, any other questions? Remember, I can't see you if you're waving at me. I can try. All right. Quite a few of your patients are here. Have you had a chance to look at some of the videos and see who's here?
Yes, I did. Yes. So thank you everyone for coming. We appreciate their support.
Yeah. Okay. Well, this is probably okay. Edna. Edna Baker, if you has a question. So if you want to unmute yourself, Edna. Edna, are you there?
Okay. I'm wondering how to instruct our young people how to protect their hearing other than loud noise.
I mean, loud noise is really the main thing that they need to be concerned with. So as long as they're careful with when they're listening to music, that they turn the volume below 50% on their phone or music player or whatever they do. And then they use, if they use earplugs, if they're going to be in a very loud environment, like a concert or a bar or, things like that, where there's very loud music, to wear earplugs in those situations. I myself always have earplugs with me, so in case I'm in an area where it's very loud, I can quickly put them in, because any little bit of damage accumulates over time. So it's really important to prevent any little bit of damage.
Very interesting. My son and grandson are both drummers, and I know they wear earplugs when they play.
Yes, definitely for drums. Oh my goodness, yes.
Right.
I mean, my children wanted to play drums, and I just said no.
Okay.
Because I can't be there all the time to make sure they are wearing their hearing protection. So I just didn't want to risk it, even though I know it's fun for them to do. But I said, you're going to learn the guitar or a piano or something, not the drums.
Well, and even with, I used to be an organist and pianist, and I didn't wear earplugs when I was playing the organ because you had to open that up to get the full sound. And I have profound hearing loss now. But anyway, that's the only thing I could recommend to them. And they do both wear hearing or earplugs when they play.
Very good, very good.
What about an open window in your car? Like the driver's side?
Yeah, it's a good question. It does definitely cause, there is a lot of sound from that. But, unless you're doing it, a lot, it's probably, for short rides, it's probably not a problem. On a highway, there probably will be, if somebody is, let's say, a truck driver and always has the window down on the left, they will sustain more damage to their hearing on that left side.
Right. Well, thank goodness for air conditioning in our cars. Thank you very much, Dr.
Yes, no problem. Thank you.
Okay, I got another question for you. Thinking about cochlear implants, what is the youngest patient you've implanted and what is the oldest patient you have implanted?
Yes, good question. So the FDA approval recently actually changed a little bit, but before that, the youngest I had done was 6 months, and the oldest I've done was 94.
That's a question I get all the time. A lot of people say, well, you know, I'm too old for a cochlear implant. I know somebody that had one at 96. So you've done, as to your recollection, 94. So what are the considerations for somebody that is older that might prevent them from being qualified to get an implant?
The main issues in an older person is really their medical status, to make sure that they are medically stable to undergo anesthesia. Even if not, we reported the first case where we did the cochlear implants under local anesthesia in the U.S. Many years ago. So it could be done if necessary, but we try to see if everything is stable. We try to do general anesthesia. It just allows us to go faster in surgery. But, you know, a lot of things that we have to worry about is cardiovascular disease, whether they're on blood thinners, you know, if they have other things that are going to be a complicating factor, like wound healing issues and stuff like that. Those are the sort of the primary things that we're concerned about in that age population.
Great. Okay.
Question, Mustafa, I have a question.
Oh, okay, okay. Mustafa, go ahead.
My question is about the cholesterol and especially triglyceride, which really precipitated in the capillary vein. Does it cholesterol or triglyceride, does it really affect on hearing loss? That's my question.
So cholesterol at a sort of a regular level, you know, a little bit moderately elevated, it wouldn't directly affect the hearing loss, but it does cause vascular disease. So it does over time cause problems. Now, the most common sort of problems that people can have that can cause hearing loss are diabetes and high blood pressure. So those things will cause hearing to go down over time. So you need to get those controlled well to prevent progression of hearing loss.
So the high triglyceride doesn't affect the hearing loss?
Not directly, no.
Okay. So any other blood circulatory that may affect the hearing loss?
Nothing, I mean, other than those two that I mentioned, you know, anything that contributes to vascular disease can, but, you know, there's no like direct relationship between any other things that are elevated in the blood with hearing loss. But, you know, long term, you know, vascular disease, people who have high cholesterol, high blood pressure, things like that will contribute to vascular disease and therefore cause hearing loss.
Thank you.
No problem.
All right. Last chance. Well, I think we are going to send you back to work now.
All right, sounds good. If you have any other questions that come up, feel free to email. I'll be happy to answer them.
I certainly will. I'll be happy to collect any questions and forward them on. And I do thank you so much for taking all of this time, and good luck in surgery today. And we hope you come back maybe next year. Yes,
absolutely. I'll be happy to. So thank you. It's always fun to be with you guys. So thank you again for the invitation.
Okay, thank you.
Have a great rest of the day. Bye-bye.
Before signing off, I wanted to say next month we're going to have Sally Tannenbaum. She's a consumer engagement manager for Med-El, and she's going to be talking about cochlear implant developments. And so that's going to be April the 13th, the same time, 11 o'clock. And I hope you will join us. And let's see, maybe we can stop sharing the screen. Okay, there we go. So here we can take a look at each other before we say goodbye. Did anybody have any questions that we want to ask of each other? Anything on your mind regarding hearing loss that we might be helpful? And you can use the raise hand or feature. No?
Yeah, I have a comment.
There you were. Hi. Georgiana, you want to have a question?
I have a comment on the hearing. If when it is my turn, I can talk. I'm Mustafa. I'm Mustafa.
Yes, Georgiana. Oh.
Right. Okay. Who is talking, me or Georgiana?
Okay, Georgiana, you have the floor. So would you make your comment?
I do. Are we talking to me or Georgia?
Georgiana, are you talking? Because we can't hear you. Nope, now you're muted. Can't hear you. Okay.
Honey, that's a raised hand in the.
There's a raised hand. Okay.
Yeah.
Barbara?
Yes, yes, yes. This is not a question. It is a comment. And I want to say with all my heart that this has been a very, very interesting meeting, that your chapter and Dr. Djalilian was so helpful to all of us. My comment is built on that. This is my opinion, if there ever could be a silver lining to the cloud of COVID, it would be these virtual Zoom meetings, which I think for most times beat out personal meetings by a mile. It's easy to get here. We don't have any traffic problems. Weather doesn't bother us. And it's just absolutely wonderful. I feel that every club, I live in Rossmore, I feel that every club here would benefit from having the kind of virtual meetings that we had today. I thank you from the bottom of my heart.
I'm so glad everybody could make it. We wouldn't have these meetings if you didn't show up. Okay. So I'm going to say goodbye to everybody. I think this is it. So have a great week. We're at the beginning of the week. We've still got a few days to go. Have a great time. Thank you.